Hi, everyone. My name is Ishak Noble, and I'm currently a third-year medical student at SUNY Upstate Medical University. Today, I'll be talking about our study, which poses a question: do MOUD prescriptions decrease opioid overdose severity in emergency department patients? The views expressed are my own and do not reflect those of the NIH. I want to start by giving an overview of the progression of the opioid crisis in the United States. Of the over 70,000 drug overdose deaths in 2017, more than two-thirds involved an opioid. From 2015 to 2016, opioid overdose deaths in the US increased by almost 28%. To put into perspective how the epidemic is affecting our emergency departments, from July 2016 to September 2017, there were over 142,000 ED visits for suspected opioid-involved overdoses. One way that physicians can tackle this issue is by prescribing medications for opioid use disorder, or MOUDs for short. This figure is from a study conducted in Baltimore from 1995 to 2009, which concluded that increased access to opioid agonist treatment, or MOUDs, was associated with a reduction in heroin overdose deaths. The main question we aimed to answer was whether or not there was a change in the prevalence of MOUD use in ED patients with opioid overdose over the past 5 years. We also wanted to see if there was a difference in risk of prescription drug misuse between patients on methadone, buprenorphine, or naltrexone. Lastly, we wanted to see if prior MOUD use was associated with a difference in mortality or hospital length of stay. This was a secondary data analysis from a prospective observational cohort and included patients with acute drug OD screened from 2 urban tertiary care hospitals, Mount Sinai Hospital and Elmhurst Hospital Center. From the overall cohort, we collected all the relevant data for the study, such as medications, intention of overdose, arrival and discharge dates, etc. SPSS was used for all statistical analyses. One of our study questions was to investigate the risk of prescription drug misuse between different MOUDs. For this study, prescription drug misuse included overdose of a patient's own prescription drug, taking a prescription drug that was not the patient's own, or a prescription drug overdose if the drug was not on the patient's medication list. Here we have the exclusion and inclusion criteria of the parent study. What I want to draw your attention to are the ones specific to the study, mainly the requirement of an opioid overdose, which was confirmed via urine toxicology. This figure shows the increasing prevalence of MOUDs over the study period. As you can see, as the raw number of opioid overdoses decrease, the MOUD prevalence actually increases. This graph shows the risk of prescription drug misuse between the 3 MOUDs. Methadone had a significantly increased odds ratio of misuse compared to buprenorphine or naltrexone. When looking at the use of MOUDs and patient outcomes, we found that the odds of death were 31% lower for patients who were on any MOUD. Also, there were no deaths from opioid overdose in patients taking either buprenorphine or naltrexone. However, because the incidence of mortality was so low, the study was underpowered to show significance for a mortality benefit. In regards to MOUD use in hospital length of stay, the mean length of stay was over 50% longer for methadone compared to buprenorphine or naltrexone. This association was also underpowered, however, due to a general short hospital length of stay for the entire cohort. Some limitations were that this was a non-interventional study, and the results may not be generalizable to all settings in the US since the data was collected from 2 urban hospitals. Also, 2015 and 2019 were not complete years, and as mentioned before, the study was underpowered for some outcome measures. The main takeaways from the study was that as the number of opioid overdoses decreased, the prevalence of MOUD significantly increased over the study period. Another significant finding was that methadone was associated with a 4-fold increased odds that prescription drug misuse was the underlying intention for opioid overdose. Given these findings, we believe that buprenorphine may be the preferable form of MOUD, as there were no association with prescription drug misuse during ED visits. I want to give a huge thanks to Dr. Alex Vanini for his mentorship throughout this whole project, as well as Dr. Lynn Richardson for many contributions. Thank you all for listening.